Can we have a round of applause, please?
So very good afternoon. I think there have been two interesting talks. One about the administrator issue, another about the prescribing practices and the challenges. But the ground reality is that why we prescribe antibiotic when we call it irrational. Probably it is the fear or it is the demand, right? So when we say fear of losing the patient, not in terms of economy here, fear of losing the patient in terms of life or getting the complication out of it, right? Or because of the fear that things may go worse, and the other thing is the unknown diagnosis. Right? We want to have our life or labs like this, right? But in between, what happens is the poor patient is behaving like this, and who is the hero? Everybody wants to be the hero. So hero here means give something and the patient is immediately walking and going home, right? But it cannot be done as a single person or single-handed person. You need a team to work towards creating the systems, creating the protocols, implementing those protocols, and then monitoring and then further improving upon it. So essentially, stewardship, it is simply means good communication between the lab and the physicians. Important components being remembered, you know that diagnostic stewardship, at least as a definition, you have understood. Because there are a lot of nurses here, they know their right 5 hours, 7 hours, 9 hours, right patient, right dose, right drug, right time, and so on. Same is true here in diagnostic stewardship. You need to have a right patient for right test at the right time, in a right manner, and so on. Okay? So there are 5, 6, 7 hours for diagnostic stewardship as well. So essentially, what is the flow? Flow is that the patient comes, it is being examined, prescription is written, tests are being ordered, antibiotic is being prescribed. Based on the test result, the antibiotic has to be further modified. So actually what we are having is that it can be divided into 3 major phases as we laboratory think of. One is pre-analytical, that means what happens before sample comes to the lab. Then is the analytical, what happens in the lab, and post-analytical, what happens after the report has been released by the lab. So diagnostic stewardship now is being categorized here, and please remember, in all 3 phases, both lab and treating team has defined role to play along with the nurses, right? So the example here is, in pre-analytical phase, if you have not taken a good history or examination, you are not going to write the correct test. Or if you do not have the protocols in place, or you are not aware of your protocols, you are not able to order the right test. Right? Same is true for the microbiologists in terms of whether they do have the right resources or the facility who can do that particular, perform those particular tests. Do they have certain guidance about these samples, how to collect it, store it, and send to the lab? Same is true for the nursing staff, whether they know from where the sample has to be collected, how it has to be collected, when it has to be collected, how it has to be dispatched, and so on. Right? Same is story with the analytical phase. All 3 are important, and same is true for the post-analytical phase. We will not be going into the detail of it in interest of time. But in all 3 phases, the 3 major stakeholders of diagnostic stewardship has to play important role. So what is a current problem, major problem? The major problem is inability to understand first what to write the test, as has been pointed out earlier. And when the test has come, interpretation of that test. I give you one or two examples here. For example, as was mentioned by Dr. Jatin about the example of typhoid fever, and Vidal test, right? We know that it is one of the most useless tests in the history of microbiology. But when you ask your students, tell me the test for diagnosis of the typhoid, only one answer comes, and that is Vidal test. The music of this word Vidal is so attractive that everybody remembers the moment they listen to it. No? That's the beauty of the system. But the fact is, if it is not done in a paired manner, it is useless, and nobody is going to wait in clinical practice to do it in paired manner unless there is a misdiagnosis or failure to make diagnosis during the initial 5, 7, 10 or 12 days. Right? Nobody is going to wait for it. The second example I am going to give you is from the interpretation, and that is the most favored test by any critical care specialist, which is the endotracheal aspirate. Anything if you grow, it has to be treated. Right? We always miss that there is a major, that we always teach actually our students also. This world belongs to microbes, not to the humans. We came almost 1.5 billion years after microbes landed on this earth. So our bodies are immersed in these microbes, inside out, right? Whole skin, everything, all orifices, your gut, everything is having microbe, and if they are not there, you can't live, right? So when you are taking endotracheal aspirate, you are definitely going to get some microbes which are more likely to be your colonizers. So there is a step, like if you have watched the cricket match and you have a third umpire review, there are steps you have to follow. First you have to see it is a no ball, right? Then you have to see the front view, whether the ball touched the bat. Then you have to see that Hawkeye, where it is telling whether there is a stick or not. And then you have to do the ball tracking. So they are very much prescribed, and always you will see, despite they know everything, they will follow all those 4 steps. Right? Same is with any clinical report. You have to learn which is the first step, which is the second step, and so on. So when we say endotracheal aspirate, first step is to check whether it is having any sign of infection into it. So any report of endotracheal aspirate, if you are getting without gram staining, it is useless, garbage report. You cannot act upon that report. Why? Because you need to look into whether the gram stain is telling you the cellular reaction, what we call it as sign of infection or presence of pus cells in a meaningful manner. Right? If it is not there, that whole Acinetobacter baumannii with more than 10 to the raised power 5 colony forming unit is just a colonizer. You need not act upon it. Right? So, first point. Second is lack of performance of parameter knowledge. So, again the normal range out of it. So, if you have a CRP, you have a ProCal, what you are going to take as normal or acceptable normal, or you will say that even if it is higher to this limit, it may be something else also. It is not the sign of sepsis. And lack of prioritization of clinical examination, which is now very much in fashion. Both hands into the pocket or one onto the mobile and just talking to the patient or telling the nurse or during the rounds, इसको ये दे दो, इसको वो दे दो, इसका क्या है? जो resident ने बोला वो सच्चे वचन हो गया. So lack of examination and that skill, that becomes very, very important bottleneck for making the correct diagnosis. So we need to ask certain questions. Do we have process? We have to process all the samples which are coming to the lab. That is another important. I will be showing you example why it should not be. all samples which may be reaching into the lab may not be even processed or may have certain special comments. What specific sample types will provide little or no critical or clinical value in collaborating with the diagnosis? We have to process samples that have no or insufficient clinical details. If you still remember, Dr. Jasanjeev Singh showed their lab request form or test request form, TRF, which is having all kinds of symptoms being written. At the top, the test is there and then symptoms are there. So the physician or the surgeon, whosoever is requesting the test, has to tell the symptomatology of the patient along with the sample they are sending to it, right? Next is, how can a microbiology lab influence the antimicrobial prescribing habits of the physicians? That's an important question. So that we will try to answer. So this is one publication which provides certain evidence that while all urine cultures may not be processed or even reported, or if reported, what special comments has to be given, and when they implemented this, how it impacted the prescription of antibiotics. So urine culture results were only released if there were cells in the on microscopy. That means if you are looking into a culture report without microscopy in urine culture, it is again a very difficult task to identify the merit of that particular report, right? Second is, if the patient is from OBS, because asymptomatic bacteria we treat only in pregnant females or immunosuppressed patients. So OBS and then related units, and then they have to label it whether the patient is pregnant or neutropenic, because your report is going to differ. At our times when I was intern, very interesting thought process goes on. Why we should tell the clinician or the lab, the clinical people, उनका क्या काम है? Test करें, report दे दें. We will see to it whether it is useful or not. But now on the other side, we understand you can't report if you do not have the clinical details, or you will be just like garbage in, garbage out. So ego principle will be held. Then whether the urine sample is from the specialized procedure, because their counts are different, the merits are different. How many of us actually have seen urine culture being reported as mixed bacterial species in a private setting? When we know almost 60% of the urine cultures will yield contaminants. We will be coming to it why that number is so large and how we can use it. So, no pyuria, bacteria or bacteria in the urine microscopy cultures are not performed in this particular study, and what they had, the modification of the protocol, and based on it, what they saw that the antibiotic prescriptions were drastically reduced. So diagnostic stewardship was independently associated with lower antibiotic consumption, which was statistically significant, and it has no effect on patient mortality or outcome. So what does that mean? So if you have a proper protocol, you have given the clinical details, and you have the algorithm at the patient end and the lab end, you can reduce the cost of testing and you can reduce the cost of treatment. So no patient with non-reported urine culture developed bacteremia from untreated. So that was the silver lining of this particular. So when you are sending the urine cultures, what all things you need to keep in mind? So one is when to send the cultures. So when to send the urine culture? Patient with fever or fever of unknown origin or worsening sepsis with no other evidence. You will definitely like to send the urine culture. But again the algorithm will delay. They will see into the microscopy and then will be going into the culture if required. Alteration in consciousness without evidence of source. There is some systemic evidence of sepsis. Unexplained fever with indwelling device. Now there is a term which we call it as culture of culture, right? But we do not want that culture of culture that today is Monday, all cultures, all patients sent from the ICU. We may not be doing it, but there are many ICUs which send all patient, all cultures on 2 days, fixed days from the ICU, irrespective of the clinical picture. So that should not be the culture of culture. Culture of culture actually means when indicated, culture must be drawn. Right? So recurrent UTIs or treatment failure or all patients with suspected UTIs. So these are to be looked into it, but in all patients with suspected UTI, there is a caveat. So, symptomatic UTI and certain factors are the only thing which you need to, in these indications you have to do it. Asymptomatic UTI we have talked about. We have talked about pregnancy, neurogenic or just neural involvement with the bladder, be it spine injury or neurogenic bladder otherwise, or immunosuppressed patient. So that needs to be kept into mind. When not to send the any female with uncomplicated UTI may not be subjected to urine culture because you have a default antibiotic prescription, 3 days treatment, and it is over. Right? Outpatient female with simple lower UTI, uncomplicated cystitis should not be subjected to culture. Any smell, odor, color, that is not an indication alone to send a urine culture. So unnecessary sampling means unnecessary antibiotics. So if you are able to choose right patient, then you can avoid and do an antibiotic prescription. So the question is, how much volume is ideal for sending a urine culture? Any take on it? Anybody can answer. I would not like to go one way. Anybody can raise hand and tell whatever the case is. It may be right, it may be wrong. That is fine. Apart from the ID physician. Yes, please. How much? So answer
3 to 5 ml, sir.
3 to 5 ml. So is it correct? Anybody who disagree with it? Please raise your hands. Nobody disagree. There are few people. How many of them are agreeing to it? 3 to 5 ml? 5 to 20 ml. So अभी नीलामी चल रहा है ना? So 5 to 20 ml. 10 to 20 ml. Okay. So answer is, you need in a routine care only 1 ml. Right? Because what we need is one loop full for microscopy, another loop full for culture, and one loop is 0.01 ml. So even half ml will do. Keeping in view of the dead volume, you say 1 ml is good enough. Why you need to know this? Because more the volume, more is a risk of contamination. Right? So in routine practice, you have to send only 1 to 2 ml, not more than that. But there are certain exceptions. So what are those exceptions? So one is, if you are suspecting mycobacterial infection, renal mycobacterial infection, 20 ml, 3 consecutive. Chlamydia, viral etiology, CMV or cytomegalovirus and so on, or certain parasitic infection. These are the only indications where you need larger volumes. Otherwise, small volumes is good enough. Right? Now this was the another article which talks about having the algorithm based. So you have given to the prescriber the empowerment to decide based on algorithm what they want. Right? So here you see that it is writing suspected UTI and then is followed by reflex to culture. That means you have empowered the lab. If microscopy is showing something, please do the culture. Right? So that is being written. So it's more of awareness and cost implication, because how you are going to bill the patient. Because you can't say that अभी माइक्रोस्कोपी भेज देते हैं, रिपोर्ट आएगा, फिर हम कल्चर भेजेंगे. Cost becomes an issue. So that kind of thing. So they have made a software and they had significantly dropped antibiotic utilization in their patient with no added adverse events in these patients. So based on various publications, there are certain recommendations or observations which have been made. The algorithm for sending urine samples for culture or subjecting to cultures only if you have the pyuria. And then there are certain exceptions. It is also important, there are certain publications which says that even if you write the bug and do not release the report, the antibiotic susceptibility, that is also helpful in doubtful cases. If you don't have the history, let the physician call back or you call back to the physician saying this is a bug, can we discuss about the patient condition to decide whether we have to release the report of antibiotics or not. So possibility of being asymptomatic bacteria is good enough if you tell that. The physician will understand asymptomatic bacteria whether they want to treat in this particular condition or not. Right? Same is clinician need to call the microbiologist to the lab based on this particular thing on it. Reflex urine protocol in patients suspected of having colic. The same way, you will be looking into the microscopy, you will like to see whether there is a new fever of unknown origin in the patient in ICU. Only then you will process for the culture of susceptibility. So in our hospital, we try to have what we call it as reflex testing. You have done the microscopy, if you find it meaningful, only then you are testing for the culture, reflex testing. So we did it into the sputum sample, one of the useless sample we call it as, because more than 50% of the sputum are nothing more than saliva. So, but even then, when we establish this reflex testing where you do the microscopy, if you have a good quality sputum by various, these are the scoring systems which are being used to look into the quality of sputum. We were evaluating the comparison between these scoring systems. So, if there is any good quality sputum which has been indicated by these scoring system, only then they will be subjected to culture. And the culture then maximally will yield you the pyogenic requirement, if Streptococcus pneumoniae or anything which is there. Those which has good quality sputum but are not yielding any significant pyogenic bug, they were being reflex tested for AFB or the TB, because we are a country where we have every fourth person infected with TB. And we could diagnose additional cases of tuberculosis, which patients, non-suspecting cases of tuberculosis by this reflex testing. Right? So that is the advantage. And 3 patients we could stop because we could get the pyogenic, we could tell them they stopped the APT, started with the normal pyogenic antimicrobials, and another 3 they were able to add upon it. So now it's part of our routine algorithm and we are doing good with it. Right? So cases with broad spectrum antibiotic therapy were de-escalated to narrow spectrum based on the cultures. APT was discontinued in 3 and another 3 patients where they were not suspecting but we got the acid fast bacilli, they evaluated and then they started with the antibiotic therapy. This is the reflex testing for the pleural fluid. So you have the gram stain, if there are cells, culture is not yielding anything, then they will be subjected to PCR. It's not directly they will be subjected to PCR. And the result were whopping, almost 43% of culture negative pleural fluid yielded Streptococcus pneumoniae. Right? In the same way, 2% were the H. influenzae and 6% Staph aureus. So that's another advantage of using the PCR facility, which is costly, based on the reflex test. So you need to empower lab to do that based on your documented evidence. This is again the reflex testing for CNS infection. So where you have a significant biochemistry and cytology and culture is not yielding anything, you conduct the PCR. So by that we were able to have many cases of pneumococcus and so-called rarest of rare cause of encephalitis, the parvovirus, we are finding it plenty. By PCR, then confirmed by the IgM antibodies. So that's another eye opener for us. So what could be the publication also say recommendations that if you have CSF pleocytosis, you can go for the PCR if you are not yielding anything, right? So that is the take home from here. Now bit of point of care tests. We know point of care test, the test which can be done at bedside or where the report can be just sent to the lab and you get the report in next 20 minutes, 1 hour, 2 hours. So that is a point of care test. So they are available for many of the things and we are using rapid malaria antigen as a buzzword. Everybody has to get it done. Or COVID-19, we have seen the effect of it, the rapid antigen test during the pandemic. Dengue enhancement, it has a good sensitivity specificity, although not recommended by the vector-borne disease control program at the moment. We have the HIV, hepatitis B, C rapid tests which are available and the same way molecular tests are available. So there are certain diseases for which there are. So the message here is you need to identify where you want to have the point of care test with rider or without rider. As has been pointed out, I can tell you another so-called reflex testing because typhoid came here. Nobody likes to go for blood culture in typhoid thinking that it will take long time. We did one single step. Any physician who is writing Vidal or typhoid for their patient, we will draw culture. We have a luxury because we are free to the patient. So we can do whatever we want in terms of it in interest of the patient. Right? So the moment we implemented that protocol, any patient prescribed with Vidal or typhoid will be subjected to blood culture. Our annual culture positive typhoid diagnosis went from 56 per year to 270 per year. So that is the impact. So if you choose the right test or you have certain mechanism of reflex testing, it definitely helps you in improving your diagnosis. So molecular test, another fashion which we are now into, right? So initially we say conventional culture will take time. The technology came where you have the blood culture bottle, once beat positive, do the PCR, give the result that day. So 11 hours for positivity, followed by another 5 to 6 hours. So next day you are getting the culture report. Then came the third technology where you just get the sample, directly do the PCR, same day report. All three are available in our country, but are being again underuse, misuse, abuse, overuse. Everything is there. So what is available? So if you have the rapid molecular assay or blood infection when we talk about, we have another interesting musical word which is called as MALDI-TOF. So any person, now you have MALDI-TOF, why can't you give a report on a same day? It has its own limitation. MALDI-TOF can only function once you have the culture positive. It has cut short the time of identification of that bug only. So which we used to have next day plate, culture is there, you have the isolate, then you will do the biochemical testing and the antibiotic, next day you are getting the report. MALDI-TOF, what it does is, you have the culture colony next day, you pick the colony within 5 minutes it will do the identification. So the advantage here is, once you know the bug, based on your antibiogram, you can have a narrower antibiotic therapy 1 day before. So that is the advantage, nothing more than that. Right? So multiplex PCR, सब कुछ कर लो. Any patient with encephalitis, PCR, CSF PCR. What is the clinical condition? What do you want? Bacterial pathogens, viral pathogens, fungal pathogens. What do you want? So that is all missing. That clinical thing is required because it has a cost. You may say biofire. Biofire can fire like anything to the pocket of the patient, It will cost 15,000 to 20,000 rupees per test. And the lab is being costed around at 8,000 rupees, right? So why to use that costly test when you can do in few hundred rupees? So PCR, if you have a directed PCR, the cost is less than blood culture. So why not do that? So it has to be used rationally. Then we have the fish and phenotypic based testing. Then there are new tests which are also coming up. Right? So non-bloodstream infection, again similar kind of tests are available. Again the fashion word, GI panel kara do, respiratory panel kara do. And you need to tell that what you are thinking about, and accordingly you have to direct your things around it. What is now challenged with these rapid tests? Over-diagnosis, false positivity. Right? So you get the respiratory sample, you get the report of 3 viruses in the empty swab. Now which one is a pathogen and what to do with that? So that's a challenge, you know. So false negative can also occur when the PCR becomes a failure because the genome has changed, because the gene which you have been targeted has changed. We have the rapid PCR test also. So let us see, when the hospital introduce the rapid multiplex PCR, what happens. So in this publication they introduced a stool PCR for diagnosing the pathogens for diarrhea. So what they found, initially there were few tests being ordered and sequentially it is going to increase because it adds values that you know which pathogen is there. But when they analyze it, what they found, that where there was no diarrhea, they were sending the test because there was some kind of vague GI disturbance being reported by the patient. The positive and negative difference was statistically significant. What does that mean? The level of irrationality of prescription of the costly test. So antibiotic, when they analyze the initiation of those antibiotics in negative GI speaker.
Can we have a round of applause, please? That was a very insightful session. Lots of learnings and lots of ground realities, I must say.